Welcome, everyone. My name is Seth Green, and I lead the Baumhart Center at the Quinlan School of Business at Loyola. And it is truly a privilege to welcome you to Innovating to Address COVID-19, which is co-hosted by the Quinlan School and by the Parkinson School of Health Sciences and Public Health. We have a very exciting agenda for all of you. You're going to hear brief welcomes from Elaine Morano, our founding dean of the Parkinson School of Health Sciences and Public Health, who will also be our moderator. And then I'll offer a brief strategic overview on social entrepreneurship, which is really at the core of what you're going to be hearing about today from an interdisciplinary perspective. As you can see, you're going to hear from 4 individuals who are working together: Amy Luke, Elizabeth Stranges, Abigail Silva, and Kate Mitchell, from across disciplines to move forward a really powerful initiative to address this moment. And then you're going to hear about 2 additional case studies, one from our Quinlan School of Business from Carolyn Comet, and one from our Institute of Environmental Sustainability, Zach Wakeman. And so with that, let me turn it over to Dean Morano.
Thank you very much, Seth. We are excited today to have you all here with us and to be showcasing some of the innovation that's going on at Loyola. And we hope that it might stimulate dialogue and questions. So please remember, if you have questions or comments, to include them in the chat. We'll be moderating and coming back to those at the end. You know, when Seth and I first started on this path towards having a Beyond Crisis Management series together, you know, our aim really was to try to provide timely and actionable information to help you all in the community, our leaders, on how to prepare for what's next. And we reflected on what might be a good topic to talk about now, here where we are in the summer, here where we are in Chicago and Illinois in reopening. How might we learn about innovation that's going on around us, and thinking as we think about responding to the pandemic as entrepreneurs. And I just want to ground our discussion a little bit with, I know, a quote that many of you may be familiar with, and this is idea of disruptive innovation. It was a term coined by Clayton Christensen a couple of decades ago in his seminal work, The Innovator's Dilemma. And that is to say, most innovators focus on trying to better meet customers' needs and just getting better and better. And that often leads to innovations that are sustaining, incremental. But then there's those disruptive innovators who respond and go after new market need a new way, and turn and flip the whole situation. And make us think differently about how we deliver things. And I think in some ways COVID-19 is that catalyst in forcing us to think differently on how we're thinking about health and healthcare and meeting the needs of our community, both economically as well as in health. And so a theme here I hope you hear is, as we learn from one another, we're focusing on cases of things that we've done here at Loyola. But really, we hope that they offer a platform for stimulating discussion or insight, and we learn from one another as we search and reapply in a rapid world of innovation that we're all dealing with right now. So it's in that spirit that I get to flip the script, so to speak, and be the one that is moderating and introducing my colleague, Seth Green, who's the founding director of the Baumhart Center, and brings extensive wisdom and knowledge around social entrepreneurism. And he's going to be starting first and giving us a strategic overview. So as we hear the individual cases, we can put ourselves into that social entrepreneur mindset. So with that, take it away, Seth.
Wonderful. Well, thank you so much, Dean Morano. And I want to build on what you're describing, because what Christensen is talking about in disruptive innovation is what's always happening in entrepreneurship, where you are building a new product, a new way of doing, a new approach that is ultimately not only going to directly serve the marketplace, but often going to change the marketplace, because like the Apple iPhone, once people can touch it, BlackBerry is no longer an option. And so everything else in the marketplace gravitates in that direction. And what I wanted to bring all of you into as we go into this discussion is the specific lens of social entrepreneurship, which is a subset of entrepreneurship that is specifically aimed towards solving social problems like health inequities that are clearly emerging amidst COVID-19. And so if you look at this diagram, what I like about it is this idea that there are so many different intersections with entrepreneurship because you can have innovation in so many different spheres, in health, in how we deal with mental issues, in how we look at, for example, business models. And so social entrepreneurship is really when you're intersecting that disruptive innovation towards a social good in particular. And this is a moment that has truly charged the social entrepreneurship community. So one network that we're very active with, as an example, Loyola, has brought together over 15,000 social entrepreneurs across 190 countries to look at innovation in this moment, not only to hopefully solve the big issue, which is a vaccine, but also the many, many visible inequities that this has exposed. So how do we make sure more people have access to distance learning? How do we reimagine education in this moment so that we don't have learning loss, especially among those who are already behind because of the systemic injustice of our world? And so in particular, what I wanted to bring you into as we think about social entrepreneurship is a way of thinking about design for entrepreneurship. So how do you go through the design process? And what's so exciting about introducing this is that you are about to hear 3 case studies that in my mind are examples of this coming to life. In one case with CERCL in a kind of broader institutional climate, in the other 2 cases because individual people took the initiative to go through this not as a big business, but as a person, thinking about how they use their talents and assets to innovate and create what I consider to be now enterprises that are really moving the needle in terms of access in one case to face masks, access in another to hand sanitizer. And so the process, as you see here, is really to start with empathy, which you see, if you can kind of see my clicker, right here at the beginning. You start by situating yourself in how do I understand the context of the design challenge, the people that are impacted. How can I sit in their shoes and really understand it from their worlds? Then you begin to define the problem. If you come up and you begin to hit into the really design-oriented phase where you're saying, here's the problem I'm trying to solve, you move into ideation where you're coming up with lots of ideas, right? I know both Caroline and Zach, as well as the CERCL group, were going through lots of different possibilities for how they could use their assets to address the definable problem. And then you're moving into what we call prototyping, where you're coming up with a minimum viable product and you're starting to think about how would I start to develop and implement this, right? We're going to talk about how you go into testing and tracing, and all of those things are iterative, and you experiment and you revise. And then finally you say to yourself, okay, how do we get to scale and grow? And that's where you get into that feedback and iteration leading to an actual model that begins to become scalable. And so with that, I want to turn it back over to our moderator because I want it to be short so that you could spend most of your time actually hearing case studies that are actually putting this model into real world.
Yeah. I love what you were saying, Seth, around the empathy and putting yourself into the shoe of your consumer, your customer, and designing from that point of view. And I think that's really a great way to segue into our first case study that is going to be co-discussed by Drs. Amy Luke, Abigail Silva from the Parkinson School of Public Health, as well as Dr. Strange's and Kate Mitchell from medical school and hospital, as well as our School of Law. And they'll be talking the case example around contact tracing and meeting the needs of community legal services, and really will showcase what does it mean to be empathetic and really understand the community needs. So I'll turn it over to you, Amy, and go from there.
Great, thank you. Good afternoon, everyone, and thank you, Elaine and Seth, for having us here to talk about our initiative. I'm just going to provide a very brief overview of the genesis of our Loyola Community Collaborative that we've called CERCL. So as many of you know by reading the news these days, the public health approach to ending infectious disease outbreaks, really whether it's measles, Ebola, or now the novel coronavirus, is a 3-pronged approach. First, there's a testing aspect. We need to know who's infected and how to get them medical treatment as necessary. Then we have the tracing aspect. We need to know who's come in contact with this infectious case and how do we support that person. can be isolation, or as we're calling it now, self-isolation or actual quarantine. And then there's the support piece. So we need to help those people who have either lost their jobs because of being infected, or having problems supplying food for their families, or whatever legal needs they may have. So for many of us at Loyola, the stay-at-home order really, particularly for those of us, I think, in health-related areas, the stay-at-home order really brought a great deal of frustration to us. We wanted to be doing something for our communities. So at the health sciences campus, the senior medical students at Stritch, they hit the ground running. They mobilized immediately. They set up a hotline for community members around COVID-19. And then they also set up systems to provide food from local restaurants, as well as tutoring care for frontline healthcare workers. The rest of us weren't really doing much of anything regarding direct action. And then by mid-April, it became very, very clear that our communities of color were suffering a disproportionate burden of both infection and disease from COVID-19. And this included many of the communities directly surrounding our health sciences campus. And to be perfectly honest, this knowledge just added to our sort of frustration and our feeling impotent. And then if we could go to the next slide, please. And then serendipity happened, I think. I view it that way, at least. I received a call from our Maywood Village trustee, Nathaniel Booker, and he was asking whether the Loyola University Health System, LUHS, whether they ran a federally qualified health center. In other words, a free clinic for people in the community of Maywood or Bellwood or Melrose Park. Well, unfortunately, Loyola does not run an FQHC. But this started a cascade of action for us. I called colleagues at Stritch, and I called colleagues at the health system. And then we got linked with those senior, very active senior medical students, as well as a bunch of staff and faculty from public health sciences, and thus the COVID Equity Response Collaborative, or known as CERCL, was born. So right now, this collaborative includes students, staff, and faculty from the Parkinson School of Public Health and Health Sciences. I'm sorry, I got that wrong. Parkinson School of Health Sciences and Public Health, Stritch School of Medicine, the Niehoff School of Nursing, the School of Law, the Departments of Public Health Sciences and Healthcare Administration, the Loyola University Health System, and of course, our community members. And so now I'm going to turn it over to three representatives from CERCL who are going to talk about our three-pronged approach to addressing the health inequities we're seeing with the COVID-19 pandemic. Thank you.
Okay, thanks very much. My name is Elizabeth Stranges, and I've been very fortunate to work with the team that Dr. Luke just described, known as CERCL. As she mentioned, it has become clear from the very first days of the pandemic that this event was going to bring further harm to communities that are already our most vulnerable, and for those of us who work in healthcare, communities in which we're already, unfortunately, struggling every time we see the poor health outcomes that result from the structural racism that is ever present in our society. So the question emerged very early on: how can we come together to minimize additional further harm to these communities, many of which are surrounding the health sciences campus? So we developed this test, trace, support goal. As Dr. Luke mentioned, this is already well established in public health literature as the way to go about curtailing the effects of COVID and reducing the reproduction number of the disease. So if you can advance to the next slide, please. So here you see data pulled from the Cook County Department of Public Health, which has been available since very early on in the pandemic. And this data is just pulled from yesterday. I've highlighted the villages of Melrose Park, Maywood, and then Cicero and Berwyn, where you can see in suburban Cook County, we are facing the highest rate of cases per 100,000 people. That's been consistent since the very early days of the pandemic. In thinking about how to bring testing, tracing, and support to these populations, we had to drill down further into the data and understand how are people in these communities getting testing? Are they able to access testing? Our gut instinct based on, years of working within these communities and understanding the barriers that exist to care was that it was unlikely that there was good access to testing. So we went to the Illinois Department of Public Health website and pulled up a little bit more data. If you could advance again. So on the left-hand side of the screen, you see rates, percentage rates for these communities, Melrose Park, Maywood, Cicero, and Berwyn. And what this represents is of the tests that are done on people in these communities tracked by zip code, what % of those tests are resulting positive? And what everyone's goal is in the pandemic is to bring this % positivity rate down. And there are different municipalities have different goals. I think what is very clear by looking at this table is the difference we see between those 4 communities that I highlighted and then a handful of the other townships in this western suburban area of Cook County, where you can see the % positivity rates, that is the people who are getting tested, how many of those are coming back positive, are much lower. So this data represents a higher rate of cases, but B, also potentially, much less access to testing, certainly to the need for, it highlights the need for testing. If we can advance to the next slide. I just included this because I really do think it's important. I think this was part of the impetus for many of us from Loyola and the community coming together is we know that racial disparities exist, and COVID has only brought them further to the forefront. So on the left-hand side, again, you see data from Cook County showing case rates by race and ethnicity in suburban Cook County, and then to the right, you see hospitalization rates as well. So again, knowing that test, trace, support is the key to communities being able to lower the reproduction number of the virus, keep it at a point where it's not, gaining a larger foothold in the community. We saw, in a multitude of ways, the need for increased amounts of testing in these communities. So if you can advance to the next slide. Our approach really has been from the beginning to embrace collaborative problem solving. So a lot of our work has just sprung from having conversations, ongoing conversations with each other, but then turning outwards and talking to people in the community and talking to public officials. The idea that any one person can solve problems of this magnitude in isolation is obviously not realistic. And so the more that we've been able to communicate and collaborate, the more we've been able to bring, expertise of others to bear on our problem, the further we've gotten in being able to innovate solutions. So if you can just advance one click. I just want to highlight in Melrose Park in Maywood, there's Coalition for Spiritual and Public Leadership, which is a community organization in which different institutions, including churches and other faith-based institutions, come together and advocate for the community. We've worked very closely with them to identify sites in the community that people would feel comfortable in and are accessible to receive a test at. We've also worked closely with Maywood together, some of the elected officials in Maywood, to go to where people are so that we start to, the barriers are removed. In terms of brainstorming ways to meet need, if you want to click one more time, early on, we connected with our colleagues in the nursing school who have a great deal of experience in community-based nursing. So they brought their experience to bear. Somebody that we talked to in our pathology department, our microbiology lab said, oh, Loyola has a mobile health unit. What if we look into that? So we reached out and we brought more people into our discussions with community leaders to talk about the feasibility of this. And then if you can advance again, we reached out to other organizations in Chicago and actually in other parts of the country that are doing similar things. So we were lucky enough to speak to amazing leaders from Project Hood who set up a test drive in their community. We also talked to our neighbors and colleagues at the PCC community wellness FQHCs, where they were able to expand testing in early days with support from IDPH. So we really have gone around collecting the expertise, input, and experience, because I think that there's something, understanding the experience, as Seth said in the beginning, empathizing with the people, in the community who are experiencing this problem, seeing it from their point of view, and then figuring out how do we go about working together with them to come up with a common solution for this beast, which really affects every single one of us. And so we've been really, really fortunate to bring together a lot of people in order to innovate and in some ways, yes, disrupt the traditional way of doing business within, the old school fee-for-service model that many of us in the healthcare industry are used to. So if you can advance to my last slide, we're really excited because we have, through the hard work of many folks in the community, many students, staff, and faculty, developed a pilot plan for 3 walk-up testing sites in our communities of Maywood and Melrose Park that we are planning to pilot the week of July 26th. Our plan is to do a 1-month pilot and to assess at week 2 or 3 how it's going, see where we might be able to expand, because we do know that Berwyn and Cicero are also very high need areas. So how we might collaborate with folks down there to expand access to testing further through collaboration. So thank you all very much, and I'm going to pass it off to one of my next colleagues to talk about contact tracing.
Thank you, Elizabeth. So I want to start by first stating that as the nation looks to restart the economy and recover from the COVID-19 pandemic, reopening entirely will depend not only on expanding public health testing, as you will just found out, but also on ramping up contact tracing efforts. In fact, one of the requirements for allowing Illinois to move into phase 4, where we are now, the revitalization phase, it includes the ability to begin contact tracing and monitoring within 24 hours of diagnosis for more than 90% of cases in a region. And according to a report from the Association of State and Territorial Health Officials, Illinois would require a minimum of 3,800 contact tracers to meet the need. So allow me to briefly describe what contact tracing is and what our team is doing to help build a cadre of contact tracers. Next. Okay, so, sorry about that. So what is contact tracing? The purpose of contact tracing in general is to help stop the community transmission of an infectious agent such as COVID-19. Broadly speaking, contact tracers identify, assess, and manage people who have been exposed to a disease. For COVID-19, contact tracing would involve interviewing people with COVID-19 to identify everyone with whom they came in close contact with during their infectious period, notifying contacts of their potential exposure, referring contacts for testing, monitoring contacts for signs and symptoms of COVID-19, and connecting contacts with services they might need during the self-quarantining period. Next. So clearly, a contact tracer must have or acquire a set of specialized skills in order to be effective. A contact tracer must not only have a basic understanding of the logistics of contact tracing and knowledge about the infectious disease that they are dealing with, but they also need to know how to maintain patient confidentiality. In addition, contact tracing or tracers need some soft skills, such as those related to communication, professionalism, cultural humility, and more. So how might a contact tracer obtain some of these skills? Next. Our contact tracing core at Loyola has leveraged currently available free online courses and have supplemented them with additional free online trainings in order to help build our state's capacity to do contact tracing the need to safely restart the economy, sustain our healthcare system's capacity to respond to new outbreaks, and support containment and mitigation efforts. So as you can see on this slide, there are currently 2 free on-demand courses that folks can take in order to receive training on the basics of contact tracing. They include modules related to the basics of COVID-19, the basics of contact tracing, effective communication and interviewing, case monitoring, ethics, and even the use of technology. Both of these courses provide you with a certificate of completion. Our training core recommends that you take both of these courses. The overlapping of content helps reinforce some of the material, and the non-overlapping material offers additional insights. Our training core felt that while these basic trainings were great, they lacked one critical component, some training on soft skills. And this was confirmed via our discussions with local health departments. We therefore mobilized to help meet this need. I will go into a little bit more detail in the next slide, but I wanted to point out that the training, go back, thank you. I wanted to also say that the training will not stop with the soft skills training. Each health department has its own different structure and protocol set in place for contact tracing. Therefore, contact tracers should expect to receive additional training once they arrive at a health department. And finally, of course, contact tracers will continue honing their skills when they practice. Next slide. So the soft skills training we offer is composed of 2 parts. The first part includes 6 online on-demand modules that introduce key concepts and skills that are critical for working with patients to improve their healthcare experiences and outcomes. Many of these concepts and skills are used by community health workers. And in fact, our team received targeted training from the Sinai Urban Health Institute's Center for Community Health Worker Research Outcomes and Workforce Development, or CROWD. And we used some of the knowledge that we gained through that training and integrated it with best practices related to contact tracing. And after completion of online modules, trainees are welcome to participate in an online interactive workshop that includes some contact tracing scenarios and role playing. Next. So you are welcome to visit our website to learn more about contact tracing opportunities and upcoming trainings. You can also request to join our listserv to receive up-to-date information on these opportunities. Currently, we have 70 people on our listserv, 30% of which are students and 70% of which are community members. And we're continuing to work with local health departments to help link students to contact tracing opportunities or to provide access to the soft skills training that we are providing. Now I want to introduce Kate Mitchell, who will inform us about the activities related to providing support to cases and contacts impacted by the pandemic.
Good afternoon, everyone. Kate Mitchell from the Health Justice Project at the School of Law at Loyola. Why don't we skip ahead to the next slide? I'm gonna talk about how we start to address the support and support the needs of people in the community who are impacted by COVID-19 because they've either been diagnosed or tested positive or have come into contact with someone who has been diagnosed or tested positive or come into contact with someone who has. But I sort of wanna, can you go to the next slide, please? So part of what our role from the Health Justice Project is to work with the healthcare providers and public health team to start to address like all the support needs that people might have when they're being impacted by COVID-19. Go to the next slide. I'm going to take just a quick step back though and tell you about the Health Justice Project and medical legal partnerships in general, just to give you some context. Our clinic at the law school is a medical legal partnership clinic. We partner with Erie Family Health Centers and Legal Aid Chicago, and we're expanding to Loyola Medicine and Maywood at the end of the summer, early fall. We have law students, social work students, and medical students working collaboratively to address the health harming legal needs of vulnerable patients. Seen by our partner health systems. We engage in holistic direct service representation and policy advocacy These are our priority areas: access to healthcare, access to healthy housing, and disability advocacy. Next. For those of you not familiar, medical legal partnerships have been around for over 20 years. They exist in over 440 health organizations in 48 states in this country, and they work to bring advocates and lawyers together with healthcare providers to identify and address health-harming legal needs and therefore improve patient health and well-being. Next. We know from research, even before the pandemic, that low-income people generally have 2 to 3 unmet civil legal needs that present barriers to health, healthy eating, healthy housing, employment, and safety. We've also seen how COVID-19 has exacerbated the social and legal needs of vulnerable populations. And so medical legal partnerships and partnering with advocates and lawyers can support patients and health systems in addressing the health harming legal needs through what we call legal care. Next. I'm going to talk very briefly about social determinants of health and then sort of explain to you how we in medical legal partnerships work with healthcare providers to identify social and structural determinants of health among patient populations and communities, and then work to address those issues through legal care and legal services. So this is the definition of the World Health from the World Health Organization on social determinants of health. Next. And this is just a visual of all of the different environmental conditions and factors that we know impact a person's health and well-being. As you can see, it's a wide variety of issues. Many of these conditions and factors have been significantly impacted by COVID-19 and the economic consequences and the educational access consequences and health consequences of the pandemic. Next. So in medical legal partnerships, we have expertise in taking those social determinants of health and working with healthcare providers through training and research development to identify social and legal needs that can be addressed to actually improve health and well-being. This IHELP screening tool is utilized in many medical legal partnerships, or some version of it in many legal partnerships throughout the country, to help guide frontline health providers and how to identify social determinants of health that could be addressed through legal care or other social supports. So our categories are income, housing and utilities, education, employment, legal status, and personal, family, and stability. Next. So we have had a team this summer of medical students, social work students, and law students working with the IHELP screening tool and building on it to include questions specific to COVID-19 and how it may be impacting patients. And I won't go through each of these, but this is the income screening question. You can see that we've added some questions here about how COVID-19 has impacted household income, access to resources. And these tools, these screening questions, are supposed to be utilized by frontline healthcare providers when they're interacting with patients to identify social and legal needs. Can you go to the next slide? So I've just provided a slide here. I'll go through them relatively quickly on housing questions. Next. Education and employment related questions. Next. Legal status related questions. Next. And personal and family stability questions. Next. So this is all of those categories together. So our students put together this screening pocket card that providers could use to guide them through what questions to ask patients to identify the social determinants of health, and with a specific lens, COVID-19 lens, so that we can identify new and emerging issues. So once the issues and needs are identified, next, our goal is to have in place supports and services to connect patients with resources in the community. So we've created a screening tool Our clinic hosts the MLP Illinois website, and we developed a COVID-19 resource webpage, which we've shared with partners and providers. This is the link to the webpage next. And this is just what the webpage looks like. There are a variety of resources available in a number of different categories. So once an issue or need has been addressed, a provider could utilize this website to connect patients with resources. And it's our hope too that we will provide staff and students to work alongside healthcare providers doing outreach to actually link patients with resources and represent patients in legal matters that impact their access to financial supports, education, healthcare, housing, etc. So thank you.
Thank you, guys. Thank you, Amy, Elizabeth, Abigail, and Kate. I think this was just a wonderful example that hits on so many of the themes that Seth introduced to us at the beginning of our conversation. Empathy, being in community, iterating and adapting to meet local needs, and taking something that may be epidemiology, public health 101, and really tailoring it so that it has a good problem solution fit for the community you're working with. So it's exciting to hear it. Now we get to hear another exciting example of entrepreneurism in action, and it's coming from Carolyn Kmet from our Quinlan School of Business. Carolyn.
Great. Thank you so much for having me here. And if you could go to the next slide. So my story starts out a little differently, and it starts out in Puerto Rico with a guy named Johnny Casanova. That's literally his name. We connected with a nonprofit organization in a municipality of Puerto Rico called Manatí. This small little city is about an hour and a half northwest of San Juan. But when you go there, the poverty rate is about 40% or higher. And the majority of the population is vulnerable. They're either elderly, they're homeless, and there's not a lot of resources. So as you can imagine, when the hurricane hit, this particular area was completely devastated. We connected with them because they had a need. When the hurricane hit, your entire infrastructure collapses. Your roads are impenetrable. Your communication systems are knocked out. You have no electricity. And as a result, what we typically view as our first responders, our police department, fire department, etc., hospitals, inaccessible. So you have the resources, but they can't get to the area of need, and you have the people who are in need who can't get access to the resources. So in an extreme situation as this, your first responders are actually your neighbors. And so the problem that we were trying to solve was, how do we get supplies from a variety of different locations? How do I identify where they are? And how do we get them to where the need actually is? So if you could move to the next slide. The solution that we came up with, and I was working with a group of about 12 graduate students on this in 2019, was to be able to have community-enabled sourcing of supplies. So we were able to build a platform where where the community was able to go out and inventory what resources they had available, and we're also able to identify pockets of need and geospatial locations of need. We presented this working prototype to them in March of this year. I went out there, presented it to them, showed them how it worked, said, we look forward to hearing your feedback, flew home, and was sheltered in place almost immediately within like 2 days. But having that platform built and ready, we were able to pivot that exact same process and the exact same solution to help an existing matching of needs and resources here in Illinois. We designed a geospatial platform and it changed the questions, so we were able to identify healthcare and medical institutions that needed PPE due to our very fast shortage. A lot of these institutions had given up their N95s to the front lines and were left basically defenseless. And then we had a lot of other people who wanted to be able to participate. They had sewing machines, they had cloth, they had elastic, they were able to make masks, but they didn't know who to send it to. So we had the exact same problem that we had in Puerto Rico, which was a lot of local supplies and resources, but the inability to connect the local resources with the entities in need. Next slide. To give you an idea of how much this evolved, this is what it looks like now, and it's a lot smaller in scale because as we started working on this, the need grew immensely, but then also people who were able to supply resources grew immensely as well. So now we have a map with a whole bunch of like little green stars scattered across it, and those green stars represent fulfilled needs. Next slide. To give you a sense of how much this scaled, we have about 500 makers that we were working with, and we just started at the end of March. We have helped over 150 different entities. We also had a team of Loyola undergraduates conducting outreach. So they would reach out and ensure that the people who were receiving masks were legitimate, so that we knew that the hard work that was going into it actually reached the people who needed it the most. And to date, we've distributed over 11,000 masks. Next slide. Why this worked. The makers were really energized by knowing that their resources were going to someplace local and that they actually had impact, that what they were creating actually helped somebody that they knew within their own communities. And so here are some pictures of people that we helped. Next slide. We were also able to reduce the strain on the supplies on the distribution chain. Because our resources were a lot of us already had the supplies to be able to make these masks. Plus, since we were able to connect makers with hyper-local needs, so instead of having to mail something to a hospital, you could just drop it off. We were able to reduce strain on our distribution system. We didn't have to depend on US Postal Service or FedEx. I mean, they could deal with much broader issues that they had to figure out, but we were able to just go back to, I'll just drop it off and knock on your door and leave it on your front porch. Next slide. We knew that this was going to be a short-term solution. Our supply chains are what make America go. Our manufacturing system, this is the force of our American corporate history. But in the event of a natural disaster, we still have to have the means in place to get the resources that we need. So we knew it was a short-term solution, but there was a lot of empathy all across the entire community because we're all impacted. So here you see a picture of, we had a grandmother who was helping us cut fabric. We have some children who are helping us kind of connect the pieces together. And a lot of us were working late at night after our jobs, after taking care of family, just trying to make sure that we could do this. And I think the core of this and why it worked is because people believe that it could happen. Next slide. They really believe that they could have an impact. And so we've seen a lot of that appreciation. If you were interested in getting involved or have any questions, I left my email down there. And then if you want to see our map, there's a link to that as well. So that's what I have. Thank you.
Thank you, Carolyn. It's really inspiring. I mean, what a great example of a pivot, as you said, going from something you've established and then repurposing it to solve a new problem quickly. And really, it's quite amazing to see the pop-up supply chain that you put together essentially overnight. And I'm sure that we will need to rely on that chain as we continue to go forward too. And deal with the ups and downs of the epidemic. So it's a wonderful example, and thank you for sharing it with us. Our last case example is coming from our Institute of Environmental Sustainability and Zach Wankman, and represents another pivot story. So go ahead, Zach.
Thanks, Elaine. I think, what I'm going to talk about with Loyola hand sanitizer production, I think, mirrors a lot of the things that Carolyn experienced. A disrupted supply chain, and a great local need. As we entered, into the early months of the pandemic, hand sanitizer went into really immediate undersupply. It was very difficult to get it. As it slowly rolled back out onto the market, a lot of that was thanks to new guidance and regulatory relief from the FDA. So the Food and Drug Administration came out and allowed non-traditional manufacturers to step in and start making hand sanitizer, which is an over-the-counter drug. They also allowed for non-traditional vendors for key ingredients, namely ethanol, which also quickly became short supply. So taking a step back really quickly, for some context, in the lower left-hand corner, you'll see a photo of the biodiesel lab. In the background, you see the equipment that we normally operate. So the biodiesel program at Loyola is an experiential learning program where we have students come in and act as the day-to-day operators of a small business and as researchers working to implement sustainable solutions on our campus. We primarily collect the used cooking oil from Loyola and all of the other universities and museums across Chicago to get turned into biodiesel, which is a renewable replacement for petroleum diesel fuel. That helps to run the Loyola shuttle buses and also generates a chemical byproduct called glycerin. And that glycerin is then repurposed and manufactured into a hand soap that is also used across Loyola's campuses. We do a number of other projects and have a number of other smaller products, but those are our two biggest impact and most visible ones. So we shut down when the stay-at-home order was issued, but then fast forward to the end of the collegiate semester at the beginning of May, and we immediately started planning for what would fall potentially look like if we were able to reopen. And as we looked at all of the PPE that needed to be brought onto campus, we realized two things. I think the first was that this could be very expensive. And the second one was that our supply chains are very vulnerable. Some of these things were available through existing vendors. Some were available through new non-traditional vendors to the university. And some were simply, not available at the time. There was a hope that they would become available as the summer went on. But that makes for a really shaky supply chain. So we looked at some of our existing resources, and the CERCL biodiesel lab in the Institute of Environmental Sustainability is really perfectly suited for making hand sanitizer. We, on a daily basis, handle large quantities of flammable material, which is the primary safety concern when producing hand sanitizer. You're handling a lot of ethanol. You need to do everything in a very clean, safe environment. You need explosion-proof pumps, stainless steel equipment. Awesome. We have all of that. We're good to go from that point. We're made for doing this. We've got special ventilation and grounding. Great. Safety, check. Let's move on to the next thing. The regulation with the guidance from the FDA, we could quickly move through that process. And so we arrived at, what would it look like if we brought this production internal to Loyola? And we went out and started looking for our own suppliers of these raw ingredients. Luckily, we were able to leverage some of our existing networks to gain access to some of these really hard to find ingredients and supplies. Plastic bottles and specifically tops, the kind of dispensing tops that you need for hand sanitizer are just not available. It's one of the major holdups to getting more hand sanitizer out on the market is plastic bottles and dispensing tops. Luckily, we were able to locate 1-gallon jugs with an existing vendor because we are an existing customer. So we were able to work with them to get 1-gallon jugs. When I called around to 12 different plastic manufacturers and distributors, the first question out of every single one is, are you an existing customer? If the answer is no, then the phone call ends right there. They can't even supply their existing customers. And so they kind of had a hard cutoff. So luckily we had somebody that we could work with. And then for finding ethanol, I was able to tap into the renewable fuels marketplace and find some ethanol plants that were upgrading their ethanol from fuel ethanol into USP grade ethanol that could be used for hand sanitizer. So this was, searching through and finding, this new supply chain was really key to us being able to move this internally. It also brought a really nice cost savings to the university. But I think, possibly the stronger motivator here was the fact that we now were in control of our supply chain. But we were, able to ensure that all of our campuses are going to have access to as much hand sanitizer as we need. And we started to expand out and look at what other packaging can we put this in besides, wall-mounted hand sanitizer stations? Can we do small spray bottles? And we were able to find a manufacturer overseas and direct import some containers with spray tops for that. Then we looked at and expanded into surface sanitizer for hard surfaces to go into spray bottles and into sanitizing wipes. And all of these products are going to be available as we reopen the campus in the coming months. So in the interest of time, I think I'm going to turn it back over to Elaine so we can move on to questions.
Yeah. Thanks very much. So this is our chance in the last 10 minutes or so that we have to do some power round questions. I've been monitoring the chat room, so just to confirm for everyone, the slides that are presented today, as well as the video, will be uploaded. You'll get a message since you registered that will be sent out to you. We're happy that the cases are inspiring. We wanted to choose some inspiring stories, frankly, for our summer. We've been through a lot, as each and every one of you have, and it's really, I think, heartwarming and uplifting to hear the entrepreneurial spirit with these stories. So I think for the sake of time and the promise that we would finish on time, I'm going to end with a power round of questions back to our speaker in reverse order. I think each of these stories presents really the entrepreneurial mindset, illustrates that iteration and learn by doing, trial and error, bringing new things together in new and different ways to solve problems in ways that aren't just what they would say are problem solution fit, but really trying to think of it as a problem, product market fit, something that could scale to the market or community we're working in. So with that in mind, I'm going to ask each one of our speakers, you represent entrepreneurs in action here with us. Is there any pearl of advice or single words that you might pass on to others that are trying to innovate in today's disruptive world of COVID-19? I'll start first with Zach. You're on.
I think so much of this is it's new to me, and I think that's not unique. We're all doing new things now, and I think the most important thing for me going into this new project, as we continue to look at expanding it, is really a commitment to transparency, and ensuring that we're communicating out as much as possible to gain as much feedback from our collaborators and stakeholders as possible. When we're doing something new like this and we're in uncharted territory like a pandemic, being transparent, I think helps open up communication, which is so important across all of these projects.
Yeah. And helps promote, as you were saying, that sustaining partnerships to be able to come together and work together in new ways. Carolyn, your pearl.
Yes, I remember a moment when I was working on this project, and this was out of my wheelhouse. My corporate background is actually in marketing and analytics, and working on these two projects was certainly out of my expertise area. And I remember being in the Quinlan elevators at one point, dry heaving from stress because I didn't know if it could get done. But there's no choice about it not getting done. And so I think that what I've learned from these experiences was to not get consumed by what seems completely insurmountable, because every step forward is definitely a step forward.
Yeah, that's good pearl of wisdom to keep us going for sure. Kate.
Yeah, I think all these projects really demonstrate how critical it is that we practice interprofessionally, because the problems that we're facing are so complex and they need all of us from all of our professions and all of our perspectives, lending our expertise and our time and our own creative innovations to be able to address and make any meaningful movement on these issues. And I really appreciate being part of a wonderful, innovative, and our professional team at Loyola.
Yeah, thank you for sharing that. That exact point is what inspired Seth and myself to try to kick off this series, recognizing it does require cross-sectoral or interdisciplinary partnerships. I think you're so very right. Abigail.
Sure, I'd like to say that I used a targeted crowdsourcing to develop the course. So I identified LUC faculty and staff who had already completed the online contact tracing courses and had some level of expertise on soft skills, clinical work experience, and invited them to join me doing the SUHI crowd training with me. And together we subsequently shaped the content and structure of the soft skills course. And this allowed me to create a better course and to do it in a more timely manner. So I've really learned this value of targeted crowdsourcing.
Yeah, and the power of finding early adopters that are energized to co-create with you. What a great example. Elizabeth?
I would say for me, I think the biggest piece that just keeps coming up again and again is related to, you know, the interdisciplinary component, but really just like the collaborative piece of this and the relationship building that's involved with whomever you're working with. One thing I've really loved about this experience is that we have people from all different backgrounds at all different levels of experience, and we have community leaders that are also involved. So always just having that flexibility and that kind of beginner's mindset where what can I learn from this person? What do they know that I don't know? Just keeping a very dynamic relationship-based collaboration can really lead to amazing things that you could not imagine on your own.
Yeah, yeah, it's really bi-directional, isn't it? It's not just one directional. You're so right. Amy.
So I actually have, I think, 4 things. I don't know if they're pearls, but they're things I've taken away. One is the importance of community and having that community voice and that community buy-in and those partners. The second is being able to identify the talent that you have around you and realizing that I have no experience in a lot of these areas that we're tapping in, but we're working in. However, I do know that we have a lot of talent at Loyola that we can tap. The third is making use of students. Our students, both at the medical school and the public health department, have been tremendous. We are working with the School of Nursing. And again, this goes back to every level. We have different skill sets at every level, but the thing about the students is they brought in a huge amount of enthusiasm and sort of stick-to-itiveness. And so that actually brings me to my 4th piece, and that is not being stymied by barriers and realizing that there are workarounds, and we will work around all of the challenges that we face as long as we keep that community in mind. What is our end goal? And it's not for our personal advancement, right? This is a true academic community relationship. And I think all of these projects lead into that. Yeah. So thank you for the opportunity to share our stories.
Yeah, it's great. It's keeping our consumer, our community in our focus so that we deliver things that are truly helpful. And we're going to be on this journey together for a while still with COVID. So thank you for sharing all of your interdisciplinary perspectives, and I'll let Seth close our session together.
Wonderful. Well, thank you so much to everyone who spoke today. I thought it was really powerful. And I just want to share that for those of you who have joined us for many of these webinars potentially, we will be off in August because we will be focused on our own reopening at Loyola, but we look forward to continuing these discussions in September. We've covered a lot about the direct public health issues, but I think to the graph that Kate showed of the social determinants, as we look forward, I think we're going to be talking even more about education, about long-term health, about essentially how we build back better, because this has not only brought new challenges, it's raised the visibility of old ones. And so we look truly forward to bringing together public health and business and other disciplines to truly move the needle and to be part of the bigger process of building back better. So thank you all for joining us, and we look forward to continued conversations in the months ahead.
Stay well, everyone. Thank you.